Hi, this is Brian Kim. I'm going to share with you episode number 7 in this surgical instrument review series. This is a caliper that Epsilon designed for me to help me with marking the conjunctiva and sclera for the Yamane technique. So this is a 2.5 millimeter and 2 millimeter caliper, and I use it for my intrascleral haptic fixation technique. And I'm also going to show in this case using the Sensar IOL. And so this patient's already aphakic. The patient had a dislocated lens, retina, removed the lens and did a vitrectomy. And so this patient's already had a vitrectomy, the lens has been removed. So this is really an ideal case for anyone who's trying to start learning how to do Yamane technique. Patient's been vitrectomized, there's no lens, it's aphakic. And so you're going to see me using this new caliper. It's really quite nice because it just makes this step so much easier. So you can see it's 2.5 millimeters on one side, 2 millimeters on the other side. And what you have to do is just put some ink marks on the tips of the caliper, and then you're ready to go. So you want to dry the surface. I'm marking, again, perpendicular radial mark from the limbus, 2.5 millimeters back, and then 2 millimeters adjacent. I'm using my cannula to find 180 degrees apart on the other side. And I like to use a cannula because it gives me a really good kind of eyeball view of finding that 180 degree apart mark. And once you make that mark with the cannula that's been marked, I'm using that same caliper, marking again radially 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent. This is the paracentesis incision for externalizing the leading haptic, which is for my trailing haptic technique. And these are my incisions I'm making in case I have to do some limited vitrectomy. This is some dispersive viscoelastic to coat the corneal endothelium and also push back any potential vitreous strands that might be there. This is a 25 gauge needle. I have it bent and pointed to the right, and I'm going to use that to help me externalize the leading haptic. This is a 30 gauge thin-walled needle. For the right side, I bend it about 9 millimeters from the tip, and you want to have it facing towards me. And then this is the left side needle. It's going to be bent at the hub and it's facing away, but it's always going to face the approach of the haptic. And this is the cartridge for the Sensar IOL. As you can see, I'm placing the lens on the injector platform, making sure it's nice and snug within the track there, making sure the leading haptic is going to be pointed into the barrel, making sure the trailing haptic is swept out. When you place the cartridge into the injector, you want to make sure that trailing haptic is swept out from the injector right there. So you saw I just swept the trailing haptic out away so that it doesn't get caught from the plunger there. If you don't do this step, you might accidentally damage the trailing haptic. Very important. So here we go. I'm going to place the 25 gauge needle through the contralateral limbal incision. I'm going to have my surgical assistant push and deliver the lens. As she's delivering the lens, I have her stop, and then I'm trying to dock the haptic on the bevel of the needle. She starts to advance it further, and as she does this, I just gently slide the needle out, and the haptic is out. And so this is an atraumatic way, without having to grab the haptic, externalizing it through that contralateral limbal incision. Pushing some dispersive viscoelastic to protect the corneal endothelium, pushing the optic back. And this is a neat trick. You want to use some forceps to pull that leading haptic up. By doing it that way, you're pulling the optic away, which gives you better access to cannulate the right side needle with the trailing haptic. So I'm holding the eye in the neutral position. I'm tunneling 2 millimeters, and then I dive down. You can see how well controlled it is and how the eye is not deformed at all with this maneuver. Very carefully, you want to slide the haptic in. This haptic is very delicate. You can bend it. And you want to dock the haptic on the bevel of the needle, and then very gently cannulate the needle with the haptic. I want to disengage the needle from the syringe, let it lay down. Internalizing the leading haptic with microforceps. Now look here, I'm not using an AC maintainer, and you're going to see why this is a mistake. I go ahead and try to pass the needle through the sclera, and look how much deformation of the sclera there is here. And again, this is because this patient's been fully vitrectomized. And so I try to do this maneuver, you see all this deformation. This is really poor form. And so this really just to illustrate why you need that AC maintainer. I go ahead and place that AC maintainer, hold the incision with the forceps, and look at this. I'm able to hold that eye perfectly still, perfectly well-formed chamber and eye, no scleral deformation, holding it in the neutral position by holding it with forceps, and I was able to have really exquisite control by passing that needle through the sclera. Using the microforceps to dock the haptic on the bevel of the needle, and it goes in really nicely. I'm pulling down with the left hand and pulling away with the right hand. I have the lens somewhat well centered, and then as that needle is being pulled out, I have the forceps in the ready position, ready to grab the haptic, and then I cauterize it. I do the same thing on the other side, have microforceps ready to grab, pulling that needle away from me. Once the haptic is externalized, I grab it so it doesn't slip back, and then I cauterize the tip. Using some forceps to push the haptic flush to the sclera, reapproximate and cover that area with the conj. And you can see this is a perfectly centered lens. I'm using some BSS to just pulse the viscoelastic out of the anterior chamber. But at the beginning of the case, I did see some few tiny little strands of vitreous. Despite pulsing with BSS, I'm actually going to go back and do some vitrectomy. And so this is placing the tenon suture through the main incision here, doing this in 8x speed. Bury the knot, and then I'm going to do my vitrectomy. I'm just going to do an anterior vitrectomy because, again, pretty much this patient's been vitrectomized, but I saw some tiny little wispy vitreous strands. I'm just going after those. And while I'm doing that, I'm also going to go ahead and proceed with performing the vitrector-assisted PI. And again, the setting is much lower. I'm going to switch. The cut rate is down to 30, and you have much better control of the size and location of the PI. You're able to get a really small, well-positioned PI this way. And then I go ahead and hydrate my incision. So again, I use this Epsilon caliper for the intrascleral haptic fixation technique. It's really made it a little bit easier, less cumbersome. I'm able to go ahead and make my marks really quickly and then transition on the other side and do the same thing. This case took me about 15 minutes to do the actual Yamane intrascleral haptic fixation needle technique. So remember, when you're doing the Yamane technique, most people use a CT Lucia lens, and unfortunately, a lot of people are really rough with the haptics. As you can see with this technique, I use the Sensar lens, and with PMMA haptics, you have to be very, very delicate. And this technique just goes to show how delicate the technique is because it really didn't cause any deformation of the haptic with the maneuvers when I did it. Use a trailing haptic first technique, which essentially is externalizing the leading haptic through a contralateral limbal incision. This brings the optic all the way away from you. When you try to cannulate the right side needle with the trailing haptic, it's really so easy. You have great view. You're able to flatten the haptic on the bevel of the needle, slide it in really nicely, switch gears and pull the leading haptic in, perform the same maneuver on the other side. You have exquisite control by holding the eye in the neutral position with the forceps. As you saw, and it perfectly illustrated the point, you need to have infusion when you're doing this maneuver. On the right side, I got away with it, but on the left side, I didn't. Again, this patient's been vitrectomized, and you saw the collapse of the eye without the infusion. Once infusion was in with, again, the 20 gauge Lewicki AC maintainer, I had perfect control of the eye, no scleral deformation, and I was able to hold the eye in the neutral position, and then I was able to tunnel that needle through the sclera exactly the way I wanted to. And as a result of that, this patient had an excellent refractive outcome. His uncorrected visual acuity at distance was 20/40, and he was very happy with his result. So I hope this was helpful to you, and I thank you for your attention.